Hello, everyone, and welcome to this evening's talk, The Heart of the Matter, A Brief History of Cardiac Nursing. The talk has been organised by the Nursing Library and Archive team at the Royal College of Nursing based in London. And as most of you know, the RCN is a UK member organisation, but thanks to Zoom, we can open this talk and welcome people from around the world. My name is Margaret Graham. I'm a member of the RCN History Forum and chair of a local RCN Nursing History Network here in Belfast. And it's my pleasure to welcome tonight's speaker. I'm joined on my couch here by Lorna Finlay, who's another member of our Nursing History Network here in Belfast. And Lorna's background early in her nursing career was cardiac care, so she'll be listening in as well. So, however, before we start, I just want to mention some housekeeping points. Many of you are probably already familiar with Zoom, but here's a few things you need to know before the event. Attendees will be muted during the event, so please turn your videos off during the talk to reduce bandwidth. There will be an opportunity after the talk to ask questions. You can either do this by raising your electronic hand under reactions or typing in the chat. If you're having trouble with Zoom, try leaving the event and clicking on the same link to rejoin. There will be automatically generated captions during the talk, so you can turn these on or off by clicking the CC button and then show or hide subtitles. Francis and Sarah are here to help, and they're in the background doing the techie stuff. So on to tonight's speaker. I, along with a colleague, had the pleasure of interviewing Professor Thompson here in Belfast for the RCN Oral History Collection. It was an enthralling afternoon hearing at first hand how his inspirational and stellar career had influenced cardiac care nationally and internationally. So it's a great pleasure to welcome and meet David again. David has over 40 years' experience in cardiac nursing in the UK, Hong Kong, and Australia, a field in which he is recognised as an international authority. He has published widely, secured major research grants, served on key national and international bodies, and received numerous honours. He was the first nurse to be elected a member of the British Cardiac, now Cardiovascular Society, and to hold a chair at the University of Leicester in cardiovascular nursing in the UK. He is a founding editor of the European Journal of Cardiovascular Nursing, ranked 2 out of 122 nursing journals worldwide, and an editorial board member of 4 other journals. David, you have an impressive list of letters after your name: BSc, MA, PhD, MBA, RN, FRCN, FAAN, FESC, MAE, and I know you're still a lecturer at Queen's University here in Belfast. So David, we look forward to your talk on the evolving cardiac care and the role of the cardiac nurse from the 60s to the present day. So over to you.
Thanks very much, Margaret. It's a pleasure to give this talk, and also to actually meet for the first time Lorna and have her presence here. She was a colleague and friend of one of the people I'm going to talk about in my talk, so I won't say any more. But also I'd like to thank the people from the RCN, the 2 Sarahs, and Francis. So I've chosen this title, The Heart of the Matter, for 2 reasons. One, I thought it was appropriate for the talk, but also my favourite author is still is, Graham Greene. And I don't know if you've ever read his books, but this is a very moving book. And I thought it was appropriate for the title of this talk. My background, just to give a bit of background, is I trained in nursing. I started nurse training in 1972 under the old hospital-based system, and then did orthopedic nursing, general nursing, and psychiatric nursing. And then at the end of my training, we were asked where we wanted to work by the matron at the time. And I said orthopedics because I'd done orthopedics. And then I said accident and emergency, or casualty as it was called then. And I was sent to work in the coronary care unit, which I didn't even know there was a coronary care unit. And so that's how I started in cardiac nursing, purely by accident, but actually loved every moment of it. And I've tried to keep involved in that ever since. So I'm based at Queen's University in Belfast. So this is my home, or the university where I work. Actually, my home is bigger than this. And I want to give a quote from one of the pioneers, really, of coronary care, and which has had an influence on my career. And this is from the biography of Frank Pantridge, who was really the founder of pre-hospital care. And he noticed, this is a quote from the foreword of his book, there are three types of people: those who make things happen, those who watch things happen, and those who wonder what happened. And I think that's a very appropriate quote for somebody who has really made an impact and made a difference in cardiac care. And I would urge you, if you can, to try and read this book, An Unquiet Mind. So the outline of my talk is very personal, it's selective, it's focused very much on the UK, but recognising that pioneering work has been done elsewhere in the US, in Canada, Australia, and the Middle East. But really, this is very UK focused. And as I say, personal and therefore fairly selective. So as an outline of the talk, I'll give an introduction and background. And then I'll talk about the 1950s to the 1960s. Then the 1970s, which I've called the emergence of cardiac nursing. The 1980s, where we saw the emergence of the new nursing movement. And then the 1990s, where I think cardiac nursing started to come of age. And then from the 2000s up to the present day, to try and demonstrate what impact cardiovascular nursing has had. And I also want to talk about some of the achievements that I think we've made, but also some of the challenges that we face. And then I want to acknowledge some of the people who've really shaped my career and to who I owe a personal gratitude. So in terms of introduction and background, I think it's fair to say that nursing has grown rapidly as a specialty. Its roots are very much in coronary care in the US, the UK, Canada, and Australia. And we've now seen the emergence of lots of professional, national and international organizations. For example, the European Society of Cardiology now have a nursing association. So do the US, the American Heart Association, the Preventative Cardiovascular Nursing Association. And in Australia, there is also a Cardiovascular Nursing Society. And these have really blossomed and continue to develop. We've also seen dedicated journals, conferences, and education programs being developed, and I'll talk about some of these in a moment. And then various clinical, educational, and research roles emerging, particularly in cardiac nursing, now called cardiovascular nursing, because it's sort of broadened its reach, but still essentially cardiac nursing. And then we've seen the emergence of university chairs in cardiovascular nursing, and I'll talk about that shortly. And then we've seen lots of networks and collaborations locally, nationally, and internationally. And I really want to focus on what the nursing role has been, the nursing contribution to CVD, cardiovascular disease, detection to prevention, management, and rehabilitation, and also in areas like palliative care. So from the 1950s to the 1960s, I've called it the dawn of coronary care because lots of things happened in the 1950s. And I think it's always good to look back as nurses to our history. And I think sometimes we forget, and we've been very poor at teaching student nurses, for example, about the history of the profession and the roles that people have. So in 1953 was a major movement, a major moment where Claude Beck, a cardiologist, a cardiac surgeon, actually firstly demonstrated that you could defibrillate a heart through an open chest. So opening the chest, he attached some electrodes to a human heart and showed that he could bring it back to life. And I'll talk about the reason why is because one of the causes of heart attacks is that it stops beating, and you can get it to beat again by giving an electric shock. But at that time, nobody really knew that. There'd been work done on animals, but nobody had really looked at humans. So this was a major sort of eye-opening moment for cardiology. And then rather than doing it through the open chest, opening the chest to expose the heart, Paul Zoll, another cardiologist in the US, showed that you could actually apply an electric shock through the chest wall using external defibrillation. As this was going on, a very influential nurse, Faye Abdallah, who actually became the Deputy Surgeon General in the US, to Elliot Coop, who then was the Surgeon General. She was the first nurse ever to achieve that position, had a great influence on the role of nursing in patient care, and was really one of the pioneers of cardiac nursing. And I'll talk about her in a moment. Interestingly, a US engineer, he wasn't a doctor, he was an engineer, William Kuhnhoven, was the first to show that by applying the mouth-to-mouth resuscitation and compressing the chest, that you could bring people back to life. And he was the first person to do that. Actually, he invented the first defibrillator, but he's never really credited with that. Is always associated with cardiopulmonary resuscitation, or CPR, as it's often called, mouth-to-mouth and compressing the chest. And that was in 1960. That was another revolutionary moment in cardiac care. And then a great hero of mine, personal hero of mine, Desmond Julian. Desmond Julian was a British cardiologist. He went out to Australia and to the US, and he invented the concept of coronary care units. And he basically thought that if you put patients together with heart disease who are at risk of arrhythmias, abnormal heart rhythms, which can cause heart attacks and cause death, if they were under 24-hour surveillance by a nurse in a selective area of a ward, which he called a coronary care unit, then you could actually save lives. And he was never really credited with this because other people across the world, Hughes Day in Kansas, people in Toronto, as well as in Sydney, in Australia and Melbourne, were credited as well at the same time. But actually, Desmond Julian was the first to talk about this concept, although the term was actually first coined by Hughes Day. And I'll talk about that again in detail later. And then in 1965, we started to see the role of nurses appearing in coronary care. And Rose Pinio in the States was probably one of the most influential nurses in this area at the time. And then closer to home, in Belfast, was a great pioneer, Frank Pantridge. Frank Pantridge thought, he actually came up with the concept of pre-hospital care. And he talked about mobile coronary cares, and he thought that rather than wait for people to be admitted to hospital and receive treatment there, it would be better to get to the patients before because of the delay in treatment. And so he coined the term mobile coronary care and came up with a mobile coronary care unit. So an ambulance that was equipped with the right equipment and the right staff to get to patients. And that was a seminal development in coronary care. He also developed the first portable defibrillator. And when I mean portable, I mean it was actually manageable. Some of the defibrillators were actually huge boxes of electrical gadgets and were so totally impractical. So he came up with this, and I'll show a picture of this shortly. And if you want to read more about this, there are a couple of articles, one by myself and Tom Quinn. And I don't know if Tom is at this presentation, but Tom is a long-standing colleague and has done a lot of work, particularly in pre-hospital care. And Desmond Julian talks about the history of coronary care in this article. So for anybody that wants to read it, that's a reference. So these are the people I've mentioned, and I thought it's always good to see pictures of people with a face to a name. So you've got Claude Beck there in the top left, then next to him, Paul Zoll, William Kuenhoven, and then Desmond Julian in the top right, and then Frank Pantridge there in the bottom left with the portable defibrillator that he developed. And these are pictures of the ambulances that were used, and I want to thank Margaret and Lorna and Margaret McCann and the Ulster Museum for showing these and letting me use them. And you can see how things have advanced since then. But at that time, this was a really pioneering development. This is Faye Abdallah. Faye Abdallah was a clinical nurse. She then became an academic. Then she became an administrator and in a very senior role in the US health system. And she coined the term progressive patient care. And she felt that what we needed to do was to improve patient care, was to organize staff, facilities and resources around the patient. It seems obvious now, but at that time, it wasn't. And so she really is credited with revolutionizing nursing care, and not just nursing care, but healthcare generally. And in fact, she contributed a lot of articles to textbooks on coronary care to show that the important role of nurses and nursing in those. And this is a picture of Rose Pinio. Sorry, it's not very clear. This is the clearest image I could get there with a defibrillator. You can see how big that defibrillator and monitor were. And she talked about the importance of intensive coronary care, which it was then. It was usually in intensive care units. And then coronary care units came about shortly afterwards. But actually, at the time, it was in intensive care. And really, the role of the nurse then was as a cardiac nurse, as a human monitor. And here are some quotes that I've selected. And this one is from the article that Desmond Julian described the concept of coronary care. And you can read this. I won't read it out for you. It's obvious what it says there. But really, it was saying that nurses could play an important role in that. And obviously, they needed to be trained, and they needed to be able to do resuscitation and to interpret an electrocardiogram. This is an electrical recording of the heart, and knowing when to identify a serious rhythm that could cause death or risk of death, and how to intervene. And then other pioneers in coronary care, again, talked about the importance of nurses and showing that if they were trained correctly, then they could save many lives. And here is another one. Interestingly, they talk about delegating to the nurse. And some people now would bridle at that, but that's what the role was at that time. And this is the sort of Bible in coronary care. And when I started working in coronary care in 1976, this is the manual that we were all sort of trained to use. And it was a manual. It's very practical. and it was very focused on physical and technical aspects of care, particularly ECGs, electrocardiograms, the tracings of the heart. This is a picture of a coronary care unit at that time, and it was familiar to me. And this was from Desmond Julian's unit in Newcastle. Desmond Julian went to the Freeman Hospital, a new hospital in Newcastle in England. He'd moved back from Australia, and he established this coronary care unit. And interestingly, the man there is reading James Bond book, but you can see how bulky the equipment is and the layout of the unit. And I remember it very well being like that. And then in the 1970s, I think we saw the emergence of cardiac nursing. So again, I'm going on my experiences, but I think it was quite true that working in coronary care, it was very much about in-service training. It was about on-the-job training. And we were trained very much in practical things like how to put a cannula into a patient's arm, wrist, to try and get treatment directly to the heart, how to defibrillate patients to give them electric shocks in an emergency, and also how to intubate, how to put an airway into patients and get oxygen to them. So it was very much the focus was very much on arrhythmia detection and suppression at that time. And that was pushed very much by an American cardiologist who actually went on to win the Nobel Peace Prize, Bernard Lown. And he was very keen on saying that really you could save lives just by arrhythmia detection and suppression. And we now know that that's not quite the case. But at that time, that was a very strong view in cardiac care. In 1970, in the UK, well, certainly in England, the University of Manchester established the first department and first academic department in the University of Manchester, and the first professor of nursing, Jean McFarlane, who went on to become Baroness McFarlane of Llandaff. And she was very influential in nursing education and about bringing an academic element into nursing rather than just on training. So very much about education. Now, there have been there was an older department. One in Edinburgh was founded in 1956, but the one in England was a bigger department, a much bigger department, and probably had more influence. And I'll talk about some of the work of that later. And just to give an inkling of what was happening in the UK, in Scotland, they just built a brand new hospital and a new coronary care unit, which laid empty for 9 months because there were no nurses to staff it. And I don't know, for those of you who are old enough, you'll remember there were peaks and troughs in nursing. So there was periods where there was a shortfall of nurses, and then there were other periods where they were probably trained too many. But it was usually a shortfall, and it was a real difficulty getting nurses to work in some of these areas. In 1972, and I'm sorry about using abbreviations, but I was trying to save space, was an organisation called the Joint Board of Clinical Nursing Studies, which was established, and that ran sort of short courses, usually between 3 and 6 months duration, sometimes up to a year, but usually around 6 months. And one of the courses that was established was in coronary care nursing. They realised that we needed more nurses and they needed to be trained systematically. And there used to be, it was a course called the 124. I remember it very well. And you were trained in the basics of coronary care. Actually, not really basics, actually quite depth. And then in another, and these had a knock-on effect on cardiac nursing, because until then, all hospital training, all nurse training was based in hospitals. It's very much on the sort of Nightingale era model. And the government invited Asa Briggs, who was a historian, to examine the role of nursing. And for the first time in his report, the Briggs report, which became a seminal report in nursing, he talked about nurses being taken out of nurse training schools and having training and education, so that they received an education, ideally in a university, but also it was matched with training, and people worked in practice rather than just in the classroom. And there's been a sort of cyclical repetition of this over the years of nursing, and we're still having debates about whether it was better in the old days rather than the new days, and whether nurses need to be based in universities or not. Then a thing called the nursing process, which I'm sure a lot of you remember, those of you in nursing, was introduced at Manchester University in 1975. And the nursing process was really a different way of looking at how we assessed patients. So there was a nursing assessment, then you would develop a care plan, and then you would implement it, and then you would evaluate it. Now, when I trained, we used to use a thing called the nursing cardex, and we used to go around and write notes. And some of the information was quite meaningless, to be honest, but at the time we thought it was quite helpful. Whereas this was a more systematic way of looking at nursing, and not just what nursing assessed, but what it actually did, and did it affect the outcomes of patients. So it's very much a sort of structure, process, outcome approach to nursing. And again, that caused quite a bit of turmoil at the time. And some groups, notably a professor of medicine who I knew quite well at Nottingham University, Tony Mitchell, basically wrote an article in the BMJ, the British Medical Journal, asking questions about the nursing process. And the title of his article was, "Is nursing any business of doctors?" And somebody wrote back, and in fact, Pat Ashworth, who is based in Northern Ireland, in Portstewart, she was at Manchester University, and she responded and said, "Of course it is, but of course medicine is also the business of nurses." Then we had another reorganisation in nursing, and we have these periodically, called the Nurses, Midwives and Health Visitors Act. And that brought in a new organisation that took over from the General Nursing Council, called the United Kingdom Central Council for Nursing, Midwifery and Health Visiting. And it had 4 branches: the English National Board, one for Scotland, one for Northern Ireland, and one for Wales. And they superseded the Joint Board of Clinical Nursing Studies. So there was more turmoil in some ways in nursing. And then at the end of the 1970s, we started to see in the major journals, which at that time were professional journals. So the 2 major journals were the Nursing Times and the Nursing Mirror. And they were read every week. Most nurses would buy these every week and read what was going on in nursing. And it would be quite an educational journal. I would say it was more of a magazine than a journal, but it was still the professional journal. And it was similar to doctors receiving the BMJ and the Lancet every week. And they were quite influential. And then the Nursing Mirror disappeared in the 80s. And the Nursing Times is still going, but the Royal College of Nursing established the Nursing Standard, and that's now a major influential journal. So we saw case studies, and I remember when I worked, just to give an example, in 1976 I was working in a coronary care unit and as a staff nurse. And I used to get bored, actually. It was a 6-bedded coronary care unit. And I was looking after a patient, and I remember it really very well, called Stanley. And he used to have runs of very rapid heart rates, which we call supraventricular tachycardia. So tachycardia means a heart rate of over 100 beats per minute. Supraventricular tachycardia is usually a heart rate of around 160. So it's very hard. It's very fast. and people get palpitations. It's very stressful. And if it's not treated, it can lead to what we call ventricular tachycardia, where the ventricles, the main pumping chambers of the heart, start to fibrillate, and that can cause death. So I looked after this patient for a long time. We used to have to give him electric shocks to put his heart rhythm back to normal, to what we call sinus rhythm. And he was obviously very distressed, and he needed a lot of care and attention. And so I wrote a case study about him. And I showed it to the sister of the coronary care unit, who wasn't particularly interested and felt that I was wasting my time and I should be giving out more bedpans and urinals to patients. And the cardiologist, interestingly, was stood at the nursing station, and he read this case study. And he said, "Who wrote this?" And the sister said, "Oh, Thompson." So sort of dismissing what I'd done. And Dr. Hunt, the cardiologist, said, "This is really interesting, really good. Have you thought of getting this published?" I had no idea what he was talking about. And as a consequence of that, I actually submitted that case study to the Nursing Mirror in 1978. And that was my first publication. I was very proud of it. And I owed a lot to the cardiologist at the time, and probably less so to the nurse, unfortunately. If you want to read an overview of what happened in nursing at that time, up to the 90s, Carol Ball, who was a nurse at St Bartholomew's, wrote a review in the British Journal of Hospital Medicine, and it's worth having a look at if you're interested. So we saw this shift from, and I've put this picture in just to show you how nursing education and nurse training has changed. So in the top left, that would be nurses learning on the job by the sister or the sister tutor or the clinical instructor, going around with the trolleys and so on. And then it was into the classroom in the bottom left, and now it's shifted to this sort of university-based higher education. And I can see advantages and disadvantages of both. Having trained under both systems, I think sometimes we've thrown out the bathwater, the baby with the bathwater. And I think there are a lot of things we can learn from earlier days, and we often reinvent things. In the 1980s, I would say this was a revolutionary moment for nursing, because we saw this discussion about the nursing role being extended and also expanded, and a shift more from the physical technical aspects to more holistic ones. So things like emotional care and spiritual care tended to be neglected. I'm not saying they were always neglected, but they weren't seen as important as looking at ECGs, cardiac monitors. So nurses would sit around in a coronary care unit looking at the monitor rather than the patient sometimes. And so this new nursing movement came about mainly because of the work of a handful of nurses that actually came from Manchester University or elsewhere, but mainly from Manchester. And an Institute of Nursing was established in Oxford at the Radcliffe Infirmary. And I actually worked there for a while under Sue Pembury, who was the founder of that. And it's very influential. And it became attached to the University of Oxford. The first time nursing had any influence at the university there. There were new developments called nursing development units that were set up. And two of them became quite well known, one at Tameside Hospital near Manchester and another one at Burford near Oxford. And they actually changed the view of a lot of nurses about nursing. And then we shifted from what we call team nursing, where nurses looked after a whole group of patients or a whole ward of patients. And I can remember doing that myself on a 36-bedded ward, being in charge, and really not feeling competent to do that, to what we call primary nursing, or my nurse, my patient, where nurses were responsible for a handful of patients and got to know them very well and could probably provide better care. Then we saw the emergence of nursing models and theories. Some of them, I would say, weren't very helpful. Some were helpful in the way that they got you to think about things, but many of them were from North America, and I felt that they were too theoretical and not actually very practical, but that was my personal view. And then we saw the emergence of other models like nurse practitioners. Then we started to see the growth of cardiac rehabilitation, which was getting cardiac patients back to recovery. And it's easy to forget how modern cardiovascular disease is. It was really only in the 1940s and 50s that cardiovascular disease became an epidemic. And that's when people realized that they needed to do something about it. And one of the ways, and many patients with heart disease died because they were kept in bed on absolute rest for weeks, with the belief that if they actually moved, they might trigger a heart attack or death. And so it was only in the 1940s and 50s that we started to see the emergence of cardiac rehabilitation, but it actually only started to really take off in the 1970s and 80s. And then we started to see nursing research being done. Probably already being done for quite a while, but actually never been called nursing research. And also specialist roles. So we saw roles like clinical nurse specialists, nurse practitioners, advanced nurse practitioners. And sometimes, again, I think there's been a plethora of these roles, and sometimes it's not clear what they are, and nobody seems to admit to being called a nurse. They seem to have lots of sexy titles, which are sometimes unclear, particularly to members of the public and to the patients to whom they're supposed to be serving. And then in 1982, and this is a plug for myself, the first book on cardiac nursing was published in the UK. And I'm embarrassed to, at the time, I thought it was really good, but now in hindsight, I can see the deficiencies of it. But it was required reading for nurses working in cardiac care. And then in 1983, the British Cardiac Society, now the Cardiovascular Society, elected the first nurse. And quite a few nurses have now been elected since, but it was very much a medical club, a cardiologist club, and very much a male cardiologist club. Then another development came along in nursing called Project 2000 in 1986, with the aim of getting nurses into higher education and getting them funded in the university sector. And again, we could debate how successful that has been. In the late 80s, we saw for the first time that rather than focus on some of the treatments that patients had, notably giving patients lignocaine to try and suppress the irregular heart rhythms, the arrhythmias, we started to see for the first time evidence that treatments could actually dilute or fragment the clot that was causing the heart attack. So just to explain, we use the term heart attack. It's also, its official name or medical term is called myocardial infarction, although that keeps changing. And we also use the term coronary thrombosis. And it basically means that there's a blockage in the coronary artery, which supplies the blood, the oxygen to the heart. And if it's not treated, then that clot can dislodge and cause a heart attack or even death. So these massive trials showed for the first time that new agents, streptokinase, for example, can dilute these clots and get rid of them. And unfortunately, one of the trials was called ISIS, which is probably not an appropriate acronym now, but meant the International Study for Infarct Survival. And that was the first mega trial really in medicine conducted at Oxford University, but across the world. And then we started to see the important role of nurses again in trying to get patients recovered quickly, and not just patients, but actually their partners and family members. And I think we tended to neglect partners. They weren't allowed to visit patients, or they were only allowed in for short times, and they were seen as a bit of a nuisance by some people. And yet we now know that the partners of patients, or the carers, or the family members, actually have just as much distress, if not more, than the patients. I mean, if you think about it, if you had had a heart attack and you were in a strange environment in a hospital with lots of equipment around you, you'd be quite distressed, thinking, am I going to survive? Am I going to have another one? And so people had severe anxiety, distress, stress. And for the first time, studies showed that if nurses intervened early on by giving the right support, psychological, emotional support and information, that could actually reduce distress very significantly. And that's the book I did in 1982, which looks very dated. And that's not a real patient, and that's not a real nurse. It was the publishers. We had to get a picture. In the 1990s, I think cardiac nursing started to come of age. It did move from hospital nurse training to universities. And again, this has been a bone of contention with some. But I think overall, it's been good. But there were periods where it wasn't particularly good. And I think some nurses got so focused on theory and models that they weren't very competent in the clinical aspects. And I think that's probably balanced out now. So in 1990, Tom Quinn, who I've already mentioned, who's been very influential in cardiac nursing, he established, in fact, he put an advert in, or a letter in the Nursing Times at the time, saying he wanted to get nurses working in cardiac care together and let's form a little group. And so he established the Association of British Cardiac Nurses. And then that became quite influential and was affiliated with the British Cardiac Society. And then it became the British Association for Nursing in Cardiovascular Care. And again, that's been a good forum for nurses to get together, share their experiences and collaborate. At the same time, the European Society of Cardiology set up a working group on cardiovascular nursing. It later became the Council for Cardiovascular Nursing and Allied Professions, because it thought that nursing was probably being too isolationist. So let's bring together other allied professions like dietetics, physiotherapy, pharmacy, occupational therapy, these sorts of groups. And that's now become an association, the Association of Cardiovascular Nursing and Allied Professions. And that's been very influential across Europe and continues to blossom. In the early 1990s, we saw the emergence of evidence-based medicine. And I was fortunate, I was working in Oxford at the time when David Sackett, who instituted evidence-based medicine, came to Oxford from McMaster University in Canada and set up the first centre in Europe for evidence-based medicine. And you would think that medicine was evidence-based, but at that time, it was estimated that the majority of medical treatments and medical practices had no sound evidence at all to them. And so that's sort of revolutionized medicine, but also has its detractors. And then nursing followed not long afterwards, and people like Nikki Cullum in the UK and nurses in McMaster in Canada developed that field. And that became, the journals evolved from that. And now there's a journal called Evidence-Based Nursing, which really looks at what is the evidence for a lot of the things that we do in nursing. And we assume that everything that we do is effective and efficient, but actually it's not. Quite a lot of it, or was quite harmful. In 1992, the UK commissioned a report to look at nurses prescribing some treatments, not the major treatments, but some, to alleviate the pressures on GPs and consultants and pharmacists. And that's grown into a sort of industry. And then, similar to evidence-based medicine and nursing, we saw the Cochrane collaboration, named after Archie Cochrane, a British epidemiologist who wrote a textbook called Effectiveness and Efficiency in Health Services. And he was basically saying there's not a lot of evidence to a lot of the things that we do, and we're wasting a lot of resources, and we're depriving patients of treatments that could be effective. And so he established that group. And within that group was the Cochrane Heart Group, of which I was a founder member. And we focus really on the effectiveness of lots of treatments, but my particular area is rehabilitation and psychological treatments for patients. The late Anne Townsend was a good friend of mine. She was the first nurse to be elected a Fellow of the European Society of Cardiology. Anne was a true pioneer. She worked with Desmond Julian in Newcastle, and she died too young. And she was a great loss to cardiac nursing. And the fact that the European Society of Cardiology, again, was another medical club, cardiology club. Another nurse who regrettably died, and I knew very well at Scarborough, Jane Cornt, she did the first studies to show that nurses could give thrombolysis, give these clot-busting agents to patients very quickly and very effectively. And she also developed the role of an advanced nurse practitioner in coronary care. And Tom Quinn, who I've talked about, developed nurse-led elective cardioversion, actually giving electric shocks to patients, but electively. So for people with irregular heart rates, where they can be treated safely and comfortably. And this is very much what a coronary care unit would look like now, or a cardiac care unit. The terms have changed, so we've moved from a coronary care unit to a cardiac care unit. I'm realising time's going on. In the 2000 to 2022 to the current day, we've seen lots of initiatives in nursing, nurse-led cardiovascular disease prevention, management, rehabilitation, and a lot of work being supported by the British Heart Foundation, for example, but also by other organisations, charities like the Chest, Heart and Stroke Association. Imperial College set up a master's degree in cardiorespiratory nursing, and quite a few nurses now have gone through that. In 2000, a major initiative was the National Service Framework for Coronary Heart Disease, led by Roger Boyle, cardiologist I used to work with at York, and now Sir Roger Boyle. And he was, with Tom Quinn actually, brought together the importance of looking at prevention of heart disease, the management of it, and the rehabilitation, and linking it all together, joined up thinking. The European Journal of Cardiovascular Nursing was established, and as Margaret said, that's become a premier journal. Linda Blue, another nurse colleague, old friend, sadly died recently. She set up specialist heart failure nurse-led clinics in Glasgow, and now they've mushroomed and blossomed across the world. And then Rose Webster, who I work with in Leicester, started to look at the needs of minority groups, although in Leicester, they're not a minority group, the South Asian population, which was the first group in the UK to become, where the white population would become a minority. And looking at the needs and experiences of that group of patients, and are the services that we're providing appropriate for them. And then a big textbook, Cardiac Nursing, was published, and that was the first time we'd had a major textbook with lots of authors bringing together the whole gamut of cardiac nursing, right from prevention through to palliative care. The British Journal of Cardiac Nursing was established. Now that's a monthly journal read by most people working in the UK anyway, in cardiac nursing. And then for the first time, the European Society of Cardiology set up a core curriculum for cardiovascular nursing led by Felicity Astin, who's now at the University of Huddersfield. And just in the last few weeks, the European Society of Cardiology have published the textbook of cardiovascular nursing. So there's been quite a lot of developments. And in this article that we did, we were trying to show cardiologists that nurses play a key role in heart disease, in prevention, in treatment and rehabilitation, and that they often lead those. And these are pictures of the journals that I've talked about, and these are pictures of the books that I've just mentioned. So I think the achievements are that cardiac nurses and cardiac nursing has been influential in promoting heart health, improving health literacy, actually helping patients navigate the healthcare system, access information, interpret for them, and reassure them. Disease management and working to reduce health inequalities, particularly for women, elderly people, ethnic minorities, and so on. They've been pioneers at patient and family education, counselling programs, looking at things like knowledge and satisfaction, adherence, but also developing outcome measures as well. I would say nurses have been at the fore of things like cardiac rehabilitation, secondary prevention, heart failure management, telehealth now, which is the big thing, digital health, atrial fibrillation, the irregular heart rate that many people have, and if it's not treated, can lead to stroke, psychosocial care, emotional and social support, and palliative care. And I think we forget that the person who set up the hospice movement was actually a nurse before she became a doctor, and she was Dame Cicely Saunders was actually a nurse, and people forget that. Also, patient health outcome and experience measures for patients with heart disease have been mainly developed by nurses. And nurses have been probably at the fore of involving patients and carers, which they should be involved in all aspects of their care. You know, what do they need? What would they prefer to have? And so on. So I would say that they've been key to alleviating disability, enhancing quality of life and well-being. I alluded basically that all these roles of nurses, and sometimes I think it's very hard to distinguish what they actually do, and there's a lot of overlap. And so I think we need to sort that out. I've given here some images of nursing, and it's quite interesting over time. In the top left, that was more of the experience I had when I trained. In the middle is a nurse who I knew actually, but smoking, as you can see, which is not a great role model now. And then in the bottom left, you can see Boris, a male nurse, which was a minority then. And then on the image on the right, that's from the current sort of image of the nursing program, which I'm not sure is very accurate, but anyway. So what are the challenges? I think we're still under pressure to show that we give high quality, safe, effective and efficient care. I think we do, but we still have to show that all the time with pressures on value for money initiatives and so on. I think it's about delivering care in not just the hospital, which is traditionally been based, but more in the community and at home and remotely through telehealth. And that's come to the fore with COVID. We've got to address the reality that patients don't just appear with one disease. They're often got multiple morbidities, and we're dealing with an aging population, many of them socially isolated, and so on. In nursing, we've still not got our skill mix right. You know, have we got the right staff to patient ratio? Have we got the right type of nurses? Are they prepared properly? And have they got accountability for what they're doing? And has that been developed with other professions? And I think that's an area that we need to develop. More innovative, flexible services, practicing to the full extent of education, which we need, but also training and experience. And I think training sometimes has been a Cinderella. And then working collaboratively with partners, as I've already mentioned, keeping pace with new knowledge, technology, and expertise. So I've gone over time, and I apologise for that. But it's always worth going back to Florence and remembering what she did. And I think sometimes we forget how pioneering she was. So the key messages are to improve, innovate, and inspire. And I think people like Frank Pantridge did that. Florence Nightingale certainly did. First of all, do no harm. And I think that's nurses should always remember. And these are all people that I would like to thank who've helped me over my career and even helped me with this presentation. And I'd like to acknowledge them. And these are pictures of some of the people I've worked with. Unfortunately, some of them are no longer with us, but they were very influential in my career. And then, as I say to novice cardiac nurses, do not let success get to your head. Do not let. Thank you very much.